Thank you, Dr. Terry. So thanks for the invitation to speak today, and I'm excited to be here. This is obviously an area of passion for mine. I love kind of a little bit of a tech nerd, so I kind of like getting the newer devices that are coming out on the market and implementing into our practice. So this is going to be a pretty text-heavy slide deck. So at the end, my email's at the end, so if anybody wants this information, I think it's a really important step-by-step process on how to get new technology into your practice. So if you want it, it's at the end. I'll send the slides over to you. So these are my disclosures. Obviously, I work with a lot of new technology, so I'm going to have a lot of disclosures there, and I'll wait the 3, 2, 1, 7 seconds. Good. The required 7 seconds. So here we go. So new technologies and new techniques. We are in a field where everything is constantly evolving. That's whether it's new technology, whether it's new surgical techniques. If you go upstairs and walk through the exhibit hall when you come to this meeting, you're going to see the future of surgery constantly. And I think that's obviously important for two reasons. One, it's going to keep you excited about what you're doing. If you're constantly doing the same thing, you're going to get bored. You're probably going to lose passion. And I think that's wrong, right? It's a disservice to yourself. It's also a disservice to your patients as well. So being involved in a society such as SAGE's, coming to these meetings, you're going to start to learn and see about new technologies and new techniques. I think that's obviously really important. And then being in a society such as SAGE's here, where they value new technology, they value us demonstrating new surgical techniques, new technology, you're going to learn, you're going to be on the cusp of the newest things coming down the pipeline. Extremely important for your practice to keep you invigorated, keep you excited. So a couple things though, a couple key notes before we go down this path is, you know, for the most part, you have to be careful on how you implement new surgical techniques. You have to be really careful on what new technology you're going to pick and implement into your practice, because when you have failed rollouts of new techs and new technologies, they can be pretty detrimental to our patients. Look at laparoscopic cholecystectomy. This was an exciting new technique. Everyone wanted to start doing it, but unfortunately, there was some issues with bile injuries, which common bile duct injuries, which we kind of, have trying to solve along the way, and we have for the most part. Hernia mesh. I mean, if you stay up past 10 o'clock and watch TV, you're going to see a commercial for a hernia lawsuit because of failed hernia mesh. And obviously, open robotic surgical techniques. We look at TARS. TARS, for example. Again, we've implemented new ways of not only technology techniques, but also how we learn. So if you look at TARS, for example, if you go on the internet, if you go on Facebook and you look at International Hernia Collaborative, we started posting all these videos on how do you do TAR. Everyone got really excited. Everyone's doing TAR. And then, before you know it, 6 months to 1 year later, we start to see, hey, I got these new complications. Here's the CAT scan. I got these Mickey Mouse defects. How do I fix this stuff? All right, so you have to be careful on how this stuff is rolled out. So a couple of definitions which I think are really important, really key here are how do you define what is a new technique and what's a new device? So if you look at the definition of modified device, so what is that? That's an existing tool. There's nothing really new about it. There's some little changes. A good example of that is going to be surgical staplers, for example, where now we have these smart staplers that are going to tell you how much pressure you're applying to the tissue. Should you wait longer before it's fired? Should you get a different size stapler, et cetera? New devices, these are completely disruptive techniques and technologies for the most part. So what are those things? Those are going to be like endoscopic suturing devices, X-Tac devices for closures of defects. Exciting stuff, completely disrupts how we manage our patients and really gets us thinking like what else can we do? And a modified procedure is one where we kind of modify them where, let's say you've been doing Nissen forever and then you want to start doing toupees, for example. So kind of a modified techniques. New procedures, again, these are totally new procedures. One example, again, is obviously TAR. For many years, when we were looking at complex hernia repairs, we were doing anterior component separation, and then we started moving toward the posterior component separation. Totally changed how we started treating these complex hernias. So that's a totally new procedure. And then finally, off-label use. Half my week, I'm doing half, off-label things. So what does that mean? That simply means that we're taking devices that are FDA approved for a certain, in a certain situation, clinical situation, and we're applying them safely in a different situation where it's not really intended, but we're doing it safely. It's what the patient needs, and there is some validity behind what we're doing. All right, so here's one perfect example. So this is just an off-label use. Again, really quick, this is a stent that's coming out of an abdomen for a chronic fistula after a failed hernia repair. So, this is using an esophageal stent. So obviously, we're not in the esophagus. There's no leak in the esophagus. This is coming through the abdomen. So good example, off-label use. This is a really exciting slide here. What does it show? It shows you where I kind of, in a timeline of where I completed residency, where I completed fellowship, and now I'm going on about 6 years out from my fellowship. When you sit down and look at all the stuff that I've implemented into my surgical practice, pretty cool. So what's important in terms of what you get in your residency and certainly in fellowship is you want to get a really, really solid foundation. All right. I went to Hershey Medical Center. My fellowship was really unique, and the fact that I did a little bit of bariatrics laparoscopically, I did a little bit of robotics. I did a little bit of advanced endoscopy, and I did a little bit of advanced ab wall reconstruction, okay? So when I left there, I had a really solid foundation in all those different fields. But when I got out into practice, I had that solid foundation, but I continued to apply what I had learned, and I was willing to adopt new techniques and new technology into my practice. So we started implementing all of these new things, and again, I hadn't learned any of this in fellowship or residency, which is significant, but I had, again, that solid foundation. So what this shows you is that, don't be afraid that once you're finished with residency, once you're finished with fellowship, that you're not gonna learn anything else. That's where the learning starts. Because once you get out, you're going to start building your confidence, but again, you're going to start hearing about these new things, and I want you to understand that you're going to have the confidence, and we're also going to give you the abilities to really continue to learn as you're moving forward in your training, and you're going to implement new techniques and new technology. So look at this timeline. So when I came out of fellowship, we started doing Botox for hernia repair, which kind of changed my practice. We're doing more complex robotic hernia repair as well. GPOM was something I never had done in fellowship. We had done POM, but when we got out, we saw that there was a significant need for gastroparesis patients. And again, we just, I applied what I had learned in fellowship. I spoke to mentors, watched some videos online, and then really, had the technique down before we did. And we were one of the first out in Long Island to do this procedure. Again, smart staplers were incorporated to our practice. A new choledocoscope, which was kind of that's a fun story, which is kind of brief, but when I got out of fellowship, again, I did a lot of advanced endoscopies, and one of the things they had told me, some of my GI colleagues, were that you could do whatever you want, but you can't do ERCP. I said, okay, so that's fine. Well, I'll tackle the problem from above, and I'll go through the cystic duct and do the same stuff that I would do through an ERCP. So that's kind of the story behind that. Robotic bariatrics. And now, as I'm getting in that 6-year mark, we're looking at, video recording for artificial intelligence, machine learning as well. And then obviously I'm always incorporating new devices like endoclosure devices. So, and what does this all mean, right? So obviously I like gadgets, I like doing new things, it keeps me excited, but it's also more importantly, you're providing a new service to your hospital, you're providing new services to your patients as well. So you're gonna become a significant asset to your hospital. So that's something to also keep in mind. Like again, all the stuff that I implemented on a timeline, what did that translate to? We're doing more complex hernias for our patients. Again, gastroparesis patients, they would come out of the woodwork. I would get referrals from across the country because these patients needed help, all right? Endoscopic closure device leaks. Again, we're preventing significant revisional surgeries for these patients. So all the stuff that you're implementing in your practice, again, it keeps you excited, but again, it's providing a significant service to your patient population, which is obviously the most important part here. So how do you introduce these new technologies? First and foremost, again, when you walk upstairs to exhibit hall, there's gonna be a lot of neat stuff, but you really have to step back and say, hey, listen, is there a need here? Do I need to implement this into my practice? How will it change my practice? Will it help my patients? So obviously that's really important. And a good example of this is bariatric endoscopy. I did a lot of endoscopic suturing, and as we started getting into our practice, we were seeing a lot of weight regain, reflux, et cetera. We said, hey, there's a significant need for these patients, so we started implementing it into our practice. And next, you have to really evaluate this new technology thoroughly, independently as well. Again, as you saw at the beginning, I have a lot of disclosures. I work a lot with industry, but again, you have to be a physician first. So you have to say, is this thing really going to be helpful for my patients? You really want to objectively look at the data, look at the outcomes, and understand if it's really going to help the patients. Next, when you feel that this new product is going to really be helpful for your patients, you need to understand what's the value analysis team, the VAT process. The VAT process is going to vary significantly from hospital to hospital. And once you kind of gain when you want to bring this new technology to your hospital, you're going to have to go through a pretty significant process. And what you want to see is you want to understand, like, who are the key stakeholders in this product. Obviously, it's the patients. Obviously, it's you, but it's also the hospitals. So you have to understand, they're also looking at some of this stuff from a dollar value perspective. You're looking at it from a clinical perspective, but you have to kind of find that common middle ground as well. I'll give you a great example. It was that choledocoscope that we were talking about. Something I really wanted to do, something I had worked on with industry, right? But I thought it could really give us a significant benefit to our patients. A good example are our patients who had bypasses, who would come into our ED with common bile duct stones. Either we would do a transgastric ERCP or an edge procedure. Now we were able to take them to the OR on the same day, clear out their common bile duct, take out their gallbladder, send them home. They didn't have to worry about an injury to their stomach or a leak, et cetera. So that was I thought that was a significant benefit for my patients. But one thing I had to remember was that I had to really, demonstrate to the hospital that this was going to be a benefit because, these things are expensive. But I showed that over time, we actually cut our length of stay down by 50%. So they were able to, got them to motivate them a little bit to get that product in-house. So again, determine the need for a new procedure. When you also are trying to implement new technologies or even new techniques, surgical techniques, take a course. Don't be afraid to say, hey, I want to learn this. I don't know how to use this device, or I don't know this technique. I want to get better at it. I want to implement it in my practice. Reach out to the various types of industry. You can also look through SAGES. There's a lot of courses there that are available to you as well. So be mindful that there's a lot of opportunities to continue to learn even after your training is done. Because in surgery especially, you're never going to stop learning. It's a continuous process. Once you even got that initial exposure to this new technique or new technology, you want to practice, you want to plan, you want to practice and plan some more. And what does that mean? That means that get on the cadavers, virtual learning opportunities, simulators, which are always getting better. Again, all the courses, if you go upstairs in exhibit hall, Sage is running courses from the start of the meeting to the end of it, where you can get on these devices. You're going to meet with the experts. They're going to teach you how to use this stuff and how to learn these techniques. Online courses are excellent as well. And go watch an expert. If there's something you want to learn, call them up, say, hey, I want to start learning this surgical technique. Ab wall reconstruction, I'll give you an example, like Conrad Bellis or Yuri Nowitzki, they're always inviting people to come and watch in their operating rooms. So don't be shy to say, I don't know how to do this, but I want to learn. There's always somebody out there who's going to help you learn this stuff. And again, sometimes you need to maybe go back and do formal training. Maybe you finish your general surgery residency and you get out there and you say, hey, I want to learn a little bit more. I want to learn advanced endoscopy. It's okay to go back and learn. It's always okay to go back to school. Introducing, again, more new technology. Once you get to this point and you're about to do your first case, make sure you get a proctor. I think that's really important because there's always nuances to every single patient. Every patient's different. There's nuances to every case. And sometimes you just need that expert there to kind of guide you through these first cases. And because your first case is always going to be your most important case. You want to have a really solid success for yourself. It's going to build confidence for your patients. And then also for your hospital, they want to make sure that you're okay to do these procedures. Failures are okay, but success on the first opportunity is always the best way to go. Patient disclosure, if you're doing a brand new procedure, let your patients know. Our first GPOM, I let them know. They were well aware of it. Sometimes you may get an IRB approval as well. Oops. Video review. I record all my cases, especially these new cases. I go back, I review the tape, I see what I did wrong, and most importantly, I'll actually show an expert my first procedure and say, hey, this is what I did. What do you think about this? How can I get better? And always, even when you're doing a case for years, go back and see how you could do it better, all right? And then finally, local national outcome monitoring. Always monitor your outcomes. Continually check the data. Sometimes there's a new technique or technology that's come out and we start learning that it may not be the best thing, and it's okay to abort on that new tech as well. Team training is also important. Get the people around you, get them invested. If it's a new technology, explain to them what you're using, what you're doing. It's always good to have the support of the people in the OR. So who should be responsible for training new technology and procedures? Obviously, specialty societies such as SAGES, experienced faculty, always lean on them. They're always going to help you. Industry is also an important component. They're always going to be supporting you with the courses, demonstrating new technology. It's okay to look around and understand what's coming down the pipeline. There's nothing wrong with that. And then finally, or a few more slides here, is that again, you need a solid foundation. Pick your, obviously pick your fellowships wisely, pick your residencies wisely, get that solid foundation so that you continually grow as a clinician. Market decision is also how you handle some of your complications. Anytime you're going to be doing a new procedure, a new technology, you're going to come across complications. But again, that's all about the prep. Remember, practice, plan, practice, plan. Always plan for the worst, and then obviously when the best happens, you're going to be okay. Get out of Dodge. I like getting out of Dodge options. So those first few poems, G poems that we were doing, I had a scope in the abdomen. I want to make sure that I didn't perforate anything, and if I did, I can go in and fix it. Now, obviously, after the first couple, we do it all endoscopically as well. Finally, who should monitor new technology, new techniques? Number one, surgeons. We should always monitor ourselves. Monitor yourself, see how you're doing, what are your outcomes. Don't be shy to share what your outcomes are as well. We can always do better. And then obviously there's governing boards, FDA, IRBs as well. A couple other things to just be mindful of. Always demonstrate the cost effectiveness of this technology. There's always a cost associated with it, and always be aware of your patient outcomes as well. Extremely, extremely important. Just want to make sure, again, it's okay to bail on poor technology if it doesn't seem to work out. Off-label, I'm going to skip that just for the sake of time. And one last thing I'm going to talk about is it's one of my favorite images here, turf wars. Even though you may have really great training and you may be well qualified, when you go to your institutions, there may be some individuals there who are not going to be happy that you're doing this stuff because they kind of don't want to share. They don't want to share what they're doing a little bit. So how do you get around that in 30 seconds? Be kind, be humble, do a really good job. Work with them. Collaboration is the key word. You don't want to get there and say, well, I'm going to show you, I'm going to do it better. It's not the way to do it. You want to collaborate because they may be also implementing things that you want to learn. And over time, that coldness will start to thaw. And for the most part, a lot of times, you're going to have really good outcomes with that. Again, I can't give a presentation in the SAGES without showing a video or two. But this is some transcholecystoscopy in our new scope, but I'm going to skip that. But this is our G poem as well. That we implemented in our hospital too. So again, these are all things I'd never done before, did them after fellowship, so with a lot of support and learning, you're gonna have good outcomes. I'm gonna skip for the sake of time. So in conclusions, field of medicine, surgery is always changing, new technology is always coming down the pipeline, and as a surgeon, again, you're responsible for determining, is a new technology or technique, is it appropriate? Is it clinically sound and safe? And always analyze your outcomes as well. And again, you're responsible for your patients. The number one thing when you implement new technology and techniques is do no harm. Thanks, everybody. I appreciate the time.